session is an opportunity to really dive deeper into the content and information each of our speakers have already shared with us today that you've heard, and the new research that the Deputy Premier also announced. And we know Queenslanders are at risk of living a shorter life than their parents, and that hasn't been seen before, so things have to change, and that's the theme that we're hearing today. So we're going to get some more insights into that, and if you do have any questions at any time, please just put your hand up and we'll run a mic to you, and because we'd love to hear from you as well. But firstly, I suppose just to everyone, I'd like to ask on the panel, and anybody answer, this question. Are you surprised or shocked about these findings when you first heard them, or did you think, yep, no, that'd be about right? Maybe we'll start with you, Robyn.
Yep, that'd be about right.
Yep.
Absolutely. So meeting Jay and talking to Rhema, yep, that'd be about right for me.
Yep. What about you, Rhema?
Yeah, that's what I would have expected.
Obviously working in this space. Now I know Jay, being from the United States and looking into this as well, what are your thoughts when you come here and hear what we're speaking about?
Well, so your basic question is, are we surprised? Of course not.
Why not?
This is an inevitable byproduct of an environment that is conducive to the accumulation of body fat. What do we think is going to happen? This is exactly what we should expect to happen. And by the way, when you know what is going to happen, you should have a pretty good idea of what to do to prevent it. And I mean, you heard some pretty good advice just moments ago on beginning with the youngest generation, and you certainly have the ability to influence, to create a new cohort effect, right? We were talking about various types of cohort effects. You have the ability now with this program to create a new type of cohort effect in this community.
And we've just heard from you, Norman. I'll come back to you about that COVID situation. But John, because we haven't heard from you yet, I'd like to get your thoughts on what we're talking about today. I mean, I would think that Queensland is a state that we love our sport. We always have for a long time. Why have we reached this point? Are kids not participating in sport as much?
Oh, I wanted to answer the first question because I was going to be contrary to the rest of my panels and say it is surprising in one very important way. And I think you made reference to one of the authors. There was a famous book in the 1960s, 70s by Thomas McEwen that tried to answer the question, why are we living longer? And the answer that everyone thought at that point in time was, well, it's got to be medicine. It's got to be improvements to healthcare, the dramatic technological innovations that have occurred in healthcare, and maybe to a certain extent public health, sanitation, clean drinking water. And those things are really, really important. But it was also lifestyle. It was also changes in lifestyle. It was changes to the workday. It was a lot of the things that you were talking about that were present in the 1950s and after post-World War II advances. Where we've got it wrong is letting those key elements that were a very, very important part of agency, which you also alluded to, run amok. And really get it wrong with diet, and really get it wrong with some of those interventions that Jay outlined, which I call them interventions, really social experiments gone wrong. So in one level, yes, it's not surprising. But in another level, it's the solutions and what we can do about it are actually right in front of our eyes.
Mm-hmm. I wonder though and I know Jay, you were talking about the fact that you've known this about the decline, particularly in the States, for some time. Why have we let it happen, or how have we let it happen? What was that point where it started to decline? Jay?
So when we made our prediction in 2005, we said it would take 10 years. And what we were anticipating was a latent effect, right? So if you conduct a hypothetical experiment on children and you have a group, half of them smoke and half of them not smoke, and you wait 10 years, you might come to the conclusion smoking isn't harmful. Why? Because it takes more than 10 years for the negative effect to express itself. It's the exact same thing with what happened beginning in the 1970s. It took decades of time for these children to live long enough to experience the negative effects of these early acquired harmful events. That was sort of the message I was giving to the Social Security Administration in 2002. I said, yeah, it hasn't happened yet, but it will, and it's visible right in front of us. I don't know, did I answer your question, by the way?
Yeah, I think so. It's the decline that's happened, which was what I was trying to get at.
I'd add to that. I'd come back to something I just said earlier. It's just, I think there was a political and cultural shift which happened pre-Reagan years, but actually was reinforced, and it was international, Thatcher and others, and which was that it really, the world moved towards, even the left moved towards it, which is that this is all about personal responsibility. If things go wrong, it's people who have got to take responsibility and step up to the mark. Now, nobody would deny that personal responsibility plays a role here, but the market doesn't work, and it was an overbelief in markets. And then Reagan gets into power, Thatcher gets into power, those neoconservatives take over, in a sense, and the left starts to get fearful about talking about regulation. It was a dirty word. So we talk about self-regulation. And in the food industry, self-regulation disadvantages the good guys. Yes. So if you're a food manufacturer and you decide you are going to reduce salt and you're going to reduce fat and sugar in your products, your competitors don't, and the taste difference, there's a taste and cost difference, you are penalized. Yeah. Regulation is actually pro-market. It creates an even playing field. Yeah. And politicians don't understand that. So how do we change that? I mean, that's obviously one of the early We have to give license, which is what Robyn was talking about, Rhema's been talking about. We have to give license to communities in the same way as they've got license now about climate change to talk about these things. You talked about before to parents, is it up to the parents? Are they to blame? But are parents able to navigate their way out of this? Are they really, do they have to have that responsibility, Rhema?
Yeah, no, so it's absolutely, they as democratic citizens have to negotiate it. They have to call their school board and ask them what they're doing. It's not about, am I getting my kids to run? And because going back to what Norman was saying, there's definitely a lot of inequality. A kid in Indooroopilly is going to have a different life expectancy to a kid in Bundaberg. But the reason I purposely did not want to stress that is I don't want parents in Indooroopilly to go, it's not my problem. So when I make my election decisions, when I vote in my councillors, I'm not going to worry about it because it's a problem for them. By making averages, we sort of mask the inequality and try to get what we call in our business the median voter to feel it's their problem. And if we can make the middle classes think it's their problem, we'll get action. If they think it's someone else's problem, we won't get action.
And, well, this would come back to COVID, I think, too, because is there a certain apathy, has COVID become an excuse for us to live unhealthily? Would you think so, Norman? No, I don't believe so. If unhealthily means that we ignore the fact that we don't exercise, we eat more because we're stuck at home. I think that was when we were locked down. People probably exercised a bit more, actually. You know, the trope of, or the meme of the dog who said, "Don't take me out for another bloody walk." Queenslanders get this a little bit, but you know, in New South Wales and Victoria, this was huge. I'm not so sure. I wouldn't do that. I think the real problem with COVID is post-COVID inflammatory disease, which is going to raise the risk of diabetes, heart disease, dementia. And we're already seeing excess deaths in those areas. Yes, Jay?
I want to go back to your last question. So I had a grandson that was born a year ago. My son and my daughter-in-law, when they were about to leave the hospital, said, "I can't believe they're going to let us leave the hospital with this child. We haven't a clue what to do." Right? And so here is an opportunity to step in and teach parents. It doesn't have to be complicated. It can be very simple on how to raise a child to have a new relationship with food. That's how you influence a generation, through the parents. You saw what? No offense to my parents. They made mistakes, but it wasn't their fault. They were doing what they were told to do, which they thought was in the best interest of their children. Here you've got an opportunity to influence a whole new generation of children right at the time in which the child is born. So send them home with that information.
Could I add to that as well? I've been seeing patients now for the past 25 years, and the number of times that they come in and they will not look at me, and they feel so guilty, and there's this guilt from the mum and dad, and they feel terrible, and they say, "Oh, my child's obese, and it's, you know, we are so busy and we are so time poor, and I'm really sorry about that and everything." And you know, my job is to, one, empower them and make them know and make them feel outraged. They should be so angry that the current environment supports them to feel like this. You know, for me, this is not okay, and I'm furious. So we should all feel that and then take that and really, really think about the way that we can change sports in schools, or the current environments, or food, or the cost of food, or the marketing. You know, everyone should feel outraged just as much as I do, and I bang on about this all the time, to the point that, you know, someone says, oh, it's the obesity police again coming over, but it's not that at all. It's not good enough. And so we've got to ensure that parents feel that, and when they leave and they get that, they make change at that point. To me, it's just as simple as that. It's hard, but it's
John,
really
you wanted
important.
to say something?
Well, I have a simple message around physical activity for some parents, which you would hope would be a relief. We'd actually prefer if parents did less with their kids around physical activity. And what we mean by that is encouraging more of that free range play that Jay made reference to, the times that some of us remember when you could go out till the streetlights came on, or till it got dark, and play on your own. I am mindful, though, when we talk about that we're talking about not everyone. And I think this is a danger in these conversations, is the term social determinants of health has been used a few times by different speakers. When we think about social inequality, it has an influence on all of the recommendations and the messaging that we're talking about. There are certainly neighborhoods in this state, in this country, where there would be genuine concern about children's safety in terms of their playing independently. But certainly in many neighborhoods, that's not the concern. And so it's adjusting the message appropriately to the social context in which we're addressing that I think is really critical here.
Of course, the way kids are growing up now is certainly different to the way we all grew up. I mean, we only had a TV. Now we have to mention the social media, the iPads, the tablets that they all want to be on, which is hindering that exercise and getting outside, isn't it? So that's with us to stay. How do we turn that around? How do we get them off and want to exercise and want to be healthy?
I mean, I do think, you know, I think, sorry to push back, but a lot of this conversation to me still feels like messaging for middle-class parents.
Yeah.
It's the evidence is that health messages are really absorbed and quickly translated into action by parents who look a lot like the people in this room. And that's not where the solution lies. The solution lies in parents who don't look like the people in this room, not having to absorb yet another message like this when they're coping potentially with, you know, food deserts around them, with unregulated gambling, you know, in the kinds of environments we know about. So to me, the conversation has to be what can governments do and what kind of policy regulations, and how do industry push back when we try to run those policy lines, and how do we make sure that those policies get translated into action against industry. That's, to me, more important than what's the message for exercise, because that's just for middle-class parents.
And
Just
then
imagine the impact of universal childcare and early childhood education. Universal, free. The social economic impact, where kids getting healthy meals in the childcare centre, and they're learning that, and they'll influence the parents. The parents will see that too. I mean, it's not the only solution, but just think of the impact of that in one thing. I mean, almost certainly part of the story with alcohol is just there's just something that's changed in an attitude towards alcohol, probably along with smoking in young people, and they're just not doing it anymore. So that's been a success. Less so in disadvantaged areas, but it is almost universal. Something we've been doing in schools, in the media, and other things that have made a difference.
Yeah, there are some schools doing some wonderful things with breakfasts for children who turn up and who haven't eaten breakfast. Does anybody have a question? If you do, just raise your hands and we'll get that microphone to you. Okay, we've got a couple. We've got one in the middle here. Have we got a microphone? Or maybe you stand up and you can shout. You look like you've got a big voice.
Leonard Rhema, Professor of Public Health, Griffith University. Thank you very much. I love the different perspectives here, but I'm especially drawn to Norman's and to Rhema's as well. Question about social inequalities and inequalities in wealth and income that I think are fundamental here. So Wilkinson and Pickett, 2009, wrote a book showing that inequalities in a country, so not just inequal areas that are disadvantaged, but just the level of inequality in a society between the haves and the have-nots, bigger inequalities associated with higher levels of obesity, lower life expectancy, more teenage pregnancy, more violence, etc., etc. So isn't that, and I know that the solution is indeed probably not at the state level, but I'd like to have some comments on whether we can change society, and with the belief in the market, if we did that, if we can also work on reducing the social inequalities, the income inequality.
Of course, the other part of Wilkinson's work is it doesn't just disproportionately affect those in the lower income strata, it actually has a negative effect across the entire spectrum.
Yes.
I mean, so this is one of your neoliberal dilemmas, is regulation is a dirty word and taxation is a dirty word. Mm-hmm. So if you look at countries like Finland and Sweden, high levels of taxation, reduced levels of inequality, and a social contract which allows that to be reinvested in things that work. And we've got a Labour Party that doesn't even want to get rid of $240 billion worth of future tax cuts.
There was another hand that I saw go up there at the back.
Vicky Clifton. Sorry, everyone. Vicky Clifton, Marta Research. A question for Robyn and for the panel. Do you think the cheapest option for Queensland is a one-size-fits-all approach? And how does that look for Gen Q?
A one-size-fits-all approach, is that the option?
I think that can never work, Vicky. I think it's really important for us to know, to get here today from the last 20 years, and I'm going to say 50 years for me, everything's changed. So whether it be about screen time or food environments or cost of living, domestic violence, housing, everything else, it is complicated. And so for us, we've got to have a range of solutions for each of those. So I wish it was a one-size-fits-all, because we would not be here today and I would be out of a job. But we have to bring every single solution brain together to work on this together. And you're absolutely a huge part of that too, Vicky. So really, really, really important. And just for you as well, the data is a huge part of that too. So we haven't spoken a lot about that, but that's a really, really important one for us as well. Great question.
We've got someone over here as well.
Yeah, hi, it's Noelle Burgess. I'm a dietitian by background, but also working with Health and Wellbeing Queensland. I'm only new, so sorry if this is out of the blue. I just wanted to note that there was a good mention of locus of control, and I think that's really important for First Nations communities. But as well as that, Rhema, the work you were doing around life expectancy linked with obesity, I was wondering if there was any work that you did or have seen around improvements on like housing, social emotional wellbeing, etc., on life expectancy, and also potentially those things impacting obesity.
That's a really good question. So I do know, I don't know about the obesity link of housing. There's certainly evidence of, I mean, of course, how permanent supportive housing in the US is associated with improved life outcomes for people who are on the margin of homelessness. So I've seen research around that. So there's some evidence that, housing first sort of approaches do have an impact. Not a lot of evidence, to be honest, less evidence than people say there is, but there's some evidence that homelessness and the fragility of being unable to manage your health because you don't know where you are, where your meds are, and so on, does lead to poor health outcomes. I haven't seen the correlation between fragility in housing and obesity. But it's not.
But it's urban design. I mean, increasingly with climate change, energy costs, the incidental exercise you get by going out your daily life.
Park space, green space, etc. Active transport.
Jay, yes?
Yeah, if I can comment on actually pretty much all three of the questions that came up. So years ago, I published a paper with the original title, Two Americas at the Dawn of the 21st Century. And it was an argument that we have two subgroups of the population that are moving in opposite directions at the same time. You've got the socially advantaged that are still experiencing a rising life expectancy, and it's not trivial. It's a pretty rapid increase in life expectancy among this subgroup of the population happening today. My guess is it's happening here as well. Then you've got this other subgroup that is experiencing the exact opposite. And the problem, of course, is that the one that's going down is a larger and growing subgroup of the population than the one that's going up. Unless you address this issue of social inequality, which is what the question that you're raising, we will not close this gap. It's not going to happen.
Absolutely.
So that issue is absolutely central to combating this pandemic, which I think is the right word to use.
Mm-hmm.
And the dilemma there is that we're focusing a lot on lifestyle factors like diet and physical activity. The literature has been very clear for more than 100 years that those lifestyle factors don't do a good job of explaining the social income gradients, social inequality gradients that exist within populations. In fact, they tend to flip around. I mean, again, to your comment you made earlier, when Surgeon General first published in the 64, I believe, on the dangers of cigarette smoking, it was immediately taken up by middle and upper middle class families. We stopped smoking relatively quickly. What happened then, we had an intensification of tobacco consumption and advertising towards lower income families, and eventually we took that over out of country and put it in poor countries where the tobacco industry managed to survive by selling its products to China and different places like that. So you're absolutely right. I think at some point you have to address the fundamental social determinants of health, which go back to political and economic redistribution, and they cut to the heart of where people feel incredibly passionate about political systems and ideologies. But those are the important and tough questions that need to be had.
So we had an interesting phenomenon occur. I'm guessing most people are unaware of this in the States. But the longest lived subgroup of the population in the United States is the one subgroup you would never expect this to happen to. It's Hispanics. Hispanics have the highest life expectancy in the United States. It's rapidly disappearing. Any idea why this subgroup has experienced this event? Maybe this isn't the best venue for asking that type of question to an audience, but the answer actually, it's called the Hispanic paradox, and it's basically a documentation of the fact that the Hispanic longevity is heavily influenced by a large cohort of migrants, first-generation migrants that come over from Latin America that are the wealthiest, healthiest subgroup of the population. They migrate to the United States. They exhibit the benefits that they carried with them. And then the second and third generation Hispanics, their life expectancy is going down because they're acquiring the lifestyle habits of the rest of the population. So it's sort of a classic illustration of this phenomenon that you're asking about right here.
And the Honolulu Heart Study showed it for Japanese migrants as well, first generation. And the longest lived group in Australia are first generation Greek Australians.
Interesting.
Yeah.
And it's a multiplicity of factors. So it's not just the Greek island diet, it's part of it, it's how they cook.
Yeah.
It's extra virgin olive oil. They're growing stuff in the garden, they're getting a bit of exercise. They eat with friends, they cook in moderate heat, therefore they're not getting pro-aging compounds in their food. And they belong to the Greek Orthodox Church, which has 100 fast days a year.
Interesting.
Getting back to what Jay was saying before about
But
the
they're not
intermittent
Michael
fasting.
Mosley fasts, and they're not time-restricted eating. They're frugal days where they don't eat animal protein. So they have vegan days. And in fact, when you look at this calorie restriction story, the problem with calorie restriction is that you lose the calorie gap. And because you go into this fierce calorie reduction and your body readjusts. So you've got to have exercise, and that maybe frugality works better and creates a calorie gap in your life, which is good for your cellular aging.
I mean, I remember my grandmother walking every day, and eating, cooking vegetables, having a bit of whiskey in her tea of a morning. She lived till she was 94. But
breakfast whiskey, that's okay.
Whiskey's all right, yeah.
Thank you, Professor.
But we've had generations before us who've been fine or fine but healthier than we are now, because when did the decline happen? I would say when we all started going out and getting takeaway and the McDonald's came.
Just be careful of the romance here. Just be careful of the romance, because there is a bit of romance about this. So if you take the Amish, for example, they'll eat 6,000 calories a day, tons of saturated fat. Alan Schuldner at Johns Hopkins, I can't remember which, has studied this in detail. They get away with that because they don't drive cars, they don't watch television, and they do work with their hands, and they're expending probably 7,000 calories a day. But, you know, in Middle Ages, they didn't live that long. You know, in the 19th century, people, you know, life expectancy was in its 40s. People did live, you know, there were elderly people, but we have a romance about the old days. What we've experienced is 3 months a year of increased life expectancy. Remember, that's an average. Bit of a dip during war years and so on. And now that's disappearing for us. So the statistic that did not change between 1890 and 1950 was your life expectancy at 50. And that's what's changed in our lifetimes. And now it's life expectancy is 75. But even that's artificial because people are dying. And this group that Jay talks about and Rhema talks about are dying before they get there.
And I think the question to ask is not what changed, but why didn't government policy respond? So early on, you know, why are we not surprised? Because we saw this 20 years ago. And yet there's been, for God's sake, it's self-regulation as a response. When did self-regulation ever be a serious response? Here's an attempt of self-regulation. Let's call speeding self-regulation. Whenever you speed, call up and give them your fine. Let's try that for self-regulation. You know what I mean? Like self-regulation, it's BS. And yet that's how we address industry so it's kind of the optics of regulation when we don't have it. We have to ask why, when for 20 years we've seen this. So to me, the interest, we have had other problems emerge in society and have had policy responses early and have addressed them. We have not done that here. And that's the question of more interest rather than, you know, harking back to what.
We did have a really effective market response to the forces that Jay identified in the 70s. When fat became the single target of focus, we came up with a whole industry to replace fat with things that turned out to be worse than fat.
Absolutely.
It was actually a very effective market response. The danger in this, though, and I think this is why the social determinants discussion is interesting, because it forces us to think about complex systems, which we don't inherently want to do because it's complex. But when we focus in on single elements, when we say fat is the culprit, physical inactivity is the problem, we need to drink more red wine so we can live a longer European health style, housing is an issue. All of these things are important, but they don't work in isolation. They work in complex ways. And so when we talk about what are we going to do to make a real difference for Gen Q in Queensland, we need to think about complex systems and complex system responses. And the comment about, you know, is it going to be one size fits all? It can't be if we think the solution has to lie partially in local knowledge and local solutions to problems that exist within communities. So if we're going to tap into that local knowledge, then by definition there can't be a single intervention. It's going to be many interventions, and it's going to be multi-pronged.
Well, you talked about fat there. What about sugar? I mean, a lot of talk about sugar needing a sugar tax. Is that something we're going to successfully get, or do you think that will be pushed back?
Well, there's always going to be pushback, but I suppose it's certainly something we should try. I mean, the evidence is mixed, I believe, and so we need evidence from interventions, and the question is with the high cost of living, you know, how does the narrative of a sugar tax play out in the current? I would be reluctant to try that conversation right now. This is not the window. We've passed the window of opportunity, I think, at least for the next few years for a sugar tax conversation, would be I don't know, everyone else knows this system better.
I might just add to that as well, is that I think that the sugar tax works. I think, though, it's just a tool within a range of tools that we can use. And right now, when you think about the cost of living and other things, I just think it's really, really important for us to stop and think whether it's the right time now to do that. So maybe there's other things now for this state right now that can work better and have a bigger impact, I think. So whether that be campaigns around marketing, or whether that be around working within sports and bringing sports and health together. So things that we haven't done well before, but we are doing now. So for me, sugar tax is fine, and that's good and that's right. But for us now, maybe let's just think about other things that we can do that can have a bigger impact now, today.
Any other questions?
My name is Dee. I'm a health consumer and a student dietitian. Just going back to, you talked a bit about migrants, but we didn't talk a lot about it in Australia. We're a very multicultural society. We have a big migrant and cold population. And sort of going back to Jay's point as well of risk factors, often people from subcontinent, Indian subcontinent especially, have higher risk factors. And, Rhema, you pointed, or I think it was Robyn, you pointed out earlier that there's maybe a 50% gap in life expectancy that's to come. Actually, I think it was Rhema.
I'll take it. If it's right.
The street's going to criticise it.
I wanted to ask, are there any figures around, and as you said, the data is quite dry here in Australia and there's not a lot of it, but is there any data around the fact that cold populations may have a similar or a higher life expectancy gap than the average Australian population? And what can we do to sort of make sure that we're taking that into account and dealing with that? Because, you don't want to make sure you're having another problem happening on the side because that population have different needs.
It's hard to study because of the effect, because of the healthy migrant effect. Because the first generation migrants, from wherever they come, are on average healthier than the people they left behind. So they're actually probably going to do better. It's subsequent generations that get polluted. I mean, you know about it.
Or we can look at refugee populations and other populations that come under different circumstances.
But your concerns are that they're being left out?
No, it's just whether there was any data sort of giving that indication, or if there has been any data that's been taken or any research that's been done to that effect.
Okay.
I think that for us, we've just begun. So we've done our report 1, 2, and 3 now, and I think these are the things that we need to explore in year. We're now in year 4, year 5, and 6 as well. So it's a very, very good point.
Another question?
Thanks, E.
Somewhere over here.
Thank you. Dom Courtney from Outdoors Queensland, and this is, outdoors part of this is about the physical activity side of things. But realistically, I think looking at what everyone's spoken about is the fact that we have a very complex but very broken system. And the biggest issue in that is the people who benefit from the problems in that system have a lot of power and a lot of control of that system, and they really don't want it to change. And I guess it sort of comes back to what Robyn said earlier about the social licence to get it to change. But how do we break that down where there are people, sitting up there in the weirdness out there in the world who are donating money to both sides of politics?
Yeah.
Because then they know whoever wins is going to listen to them. And, I guess that's the question of how do we get the whole community? And I think it's climate action is probably an example where there's still the brakes are on, but it's starting to come through. But how do we actually get to that social licence for the whole community to say, no, it's not good enough?
Could I just add to that? The DP said today, the bloke who used to be the health minister said today, he's going to get that all day, I think, that will be in the paper. I forgot what I was going to say now. No, I'm old. I'm post 50. I think it's important though to know that for me, because I'd been a part of the system for 25 years, I did get very frustrated, and I really didn't know that he knew that as well. It must have been in my face at the time, but government now is is working together and thinking about sport and schools and health and things together at the moment. So this is not me now coming into government going, we have to do this, and you've got to think differently. For me now it's nice because there's, we can now work with universities and different departments as well, and think about solutions together. For me in this role, it's the most important thing for me to do is to bring everybody together, because everybody here is just incredibly smart and they always want to do the right thing. So now we've got everybody sitting in a room now going, so how do we do this together so that we can change things now? So I've been around for a long time, but I've got to say that I feel like now is the time that things are really there. They move and they're going in the right direction for now. So that's why my friends are here to say, we've got to be doing this better. We've got to be doing this better together, and we've begun that already. So we've got this already, but it's got to keep on going for us to know that in 2026 to invite you back, things will change. If I didn't think that, I would not be sitting here today.
When will be that point, though, that we know that we're starting to turn things around? What will we notice? Anyone?
Well, so this is a really important question, right? Because anytime you create an institutional change like you're proposing, you have to measure the consequences across time. And you have to be patient because you may not see the benefits for a while. My guess is you'll probably see them much quicker than you might imagine. But for sure, as you're developing this program, make sure you formulate the metrics that measure success and failure. You need to know whether it works. That's a whole different story on the metrics that you're going to use in terms of health span. And there's surveys that you can do to assess the health status of the population among the different strata within the population to make, to see whether or not you're equalizing at all. But this is a really important question for an organization that is creating a program of this magnitude. Make sure you have the metrics to document what you're doing.
It's not going to happen overnight. And I think you've asked a couple of times the question, when did this emerge? And you've heard actually a number of different answers. There's a couple of keystone dates that we throw out where we can trace things, but the problems we have now are not the result of the last 20 or 30 years. I'm not even sure that it's since the 1970s. I think if you think about the evolutionary argument around energy storage, then it would suggest that what's happened in the last couple hundred years has been an acceleration of an evolutionary process that's created some really significant challenges for us. And we're not apt to get out of it anytime soon. And we're apt not to get out of it within the single cycle of a government, which is a really significant challenge for us because the government cycles are working against us on that front. So it is about measurable outcomes, but it's about timescales that are realistic as well.
But are we out to get out of it when the children are being born this year reach 20? Will they be healthier at 20 years of age in 20 years?
I'm going to say that I feel so positive about this today. We've had the Governor of Queensland plus the bloke that used to be the health minister both come today and say this is one of the most important things that they can invest in. For me, that's number one. That is the most important thing and the most important change and the most important message. It is crystal clear. Everybody now, leadership now is listening and working together to make a change. For me, that's our number one.
Is it disappointing though we have to reach this point where it's a crisis? Is it a crisis? Is that what you'd call it? Before someone takes action?
What's the definition of post-crisis? We've had the crisis and now we're beyond that.
Well, the incidence rates of type 2 diabetes would suggest that if you're not already in a tsunami of healthcare crisis, you will be very, very soon. So I think it is, somebody used the word pandemic. I think it was you, Norman, and I agree. That is a crisis.
One of the things that I've been advocating is this idea of a public health ring fence. The challenge for public health spending is that it's long-term and has to go beyond a few election cycles. So the problem at the moment is that public health spending goes up and down, and it goes down because everyone can see acute personal health spending. They can see when there's a queue at the hospital, but they can't see the public health piece of it. So in order for the public health spending not to be responding to political signals, we need to institute a different way of public health spending. And I wrote a piece in the conversation which argued that one way to do that is to actually impose a thing called a public health ring fence, where, and I think Australia spends about 0.01% of healthcare in public health. Public health ring fence probably should be about 1% of healthcare on public health. And you ring fence that, you audit against the ring fence, and you stick to,
5%.
5%. Oh, 5%. Oh, sorry.
My whole team put their hand up there, and I just wanted to point that out.
So I think until we have strategies for going beyond political cycles, we're going to be constantly going behind the crisis.
I think we've got another question up here. Yes.
Hi, my name's Oliver. I'm from the University of Queensland. This has been fabulous. There's an understanding now that obesity is one of multiple synergistic pandemics, undernutrition and climate change as two, and now COVID. And this synergistic effect, a syndemic, they've called it, has common underlying societal drivers. They co-occur at the same time and place. And they affect everyone globally. And I just wonder if we, Rhema, leveraging your comments, if we could leverage the social license created for climate change already to enact policy change that could have downstream effects for obesity at scale, and the comments of everyone.
Someone at the very back who wants to put that up.
Well, they do have common origins to some extent. So if you actually have active transport, green transport, you're walking more to the station and what have you, that's going to help your obesity problem as well. So there is a conjunction of circumstances. The problem that we've got is that Rob Moody at School of Global Health and Population Health in Melbourne often says, there's no, exactly what Rhema's saying, there's no waiting list for prevention. And therefore you don't have that political crisis. But we respond much more, Dan Kahneman talks about this, to acute crises than we do to slow-moving ones. We're just designed to worry about the saber-toothed tiger in the grass rather than the fact that the grass is burning because of climate change. And somehow we've got to reframe it.
It's very hard for you to show the things that you have prevented.
When prevention works, nothing happens.
When prevention works, nothing happens. It is the most difficult thing that you can show.
Good point. Someone's right up the back wanted
Robert
to question.
Hunt is at the back. He's got his hand up. There's a mic coming, I think. It's just for those online. Rob, sorry.
So we're talking about life expectancy on the decline, and what does this mean for our kids? So now we've got the microphone in your hand.
Hello. Robert Hunt, Dietitians Australia. I was just going to support Rhema's comment about spend in public health. So this morning, Public Health Association, ourselves, quite a few other groups were on the steps of Parliament House in Victoria promoting 5% spend on health promotion, preventative health. As I see it, and as our organisation sees it, we have the answers. We know there's a problem. There is a will. It just needs to be, the dots need to be joined. What we need is the money.
I'm glad I made sure that microphone got to you there.
Anybody else got the hand up? I thought I saw one over here.
G'day.
Have we got a microphone up there, or do you want to yell?
Sorry.
Have you got one?
My name's Phil Carswell. I'm a consumer advocate. I have been for years. I've come to these sort of seminars for decades, and it's always full of good people, good-intentioned people with good hearts, and very clever people telling us what we generally usually know or feel in our guts. But what we're really talking about is changing power, and that requires people to do something. Setting a seminar is terrific to get evidence and to get information and support from fellow people. But if we want to make change, we've got to get our hands dirty and go and get involved in those processes that make change. I'd like to ask, for example, how many people here belong to their local branch of any political party?
Few hands up. 1 or 2, 3.
Because that's where the conversations need to happen. If we're going to make change, it's conversational. We need to talk to people who trust us and who we know, who will listen to us, and who will then band together to help make change. And the best way I know how that happens is in my local branch meetings, where I can sit and talk and listen, and know that those ideas can filter into policy and then into platform and then from there into ministerial obligations. Stephen Miles knows all about this because I've done it to him. I don't see why all of us can't do it to our local members and at our parliament as well. We've got to make change by engaging people at the grassroots and then pushing that change up by getting all the branches together.
So, Phil, we've got a very strong equity strategy, and you're a really, really big part of that, as you know. And so this is exactly the things that we've got to do together. You're absolutely right, absolutely right.
Thank you. We have another one here in the front row, I think.
Yasmina Yoldich, Queensland Health. Thank you very much. That is amazing to listen here. And I am outraged, Robyn, absolutely I am. But I guess my question is around quality of life. We talk about the 5 years. If you asked me today if I would be prepared to give up five years of my life, not turn 85, but turn 80, I'd say, yeah, that's fine. I'm comfortable with that. But what I'm not comfortable with is the lack of quality of life that comes with that. And I don't think we talk about that sufficiently to say what it means to actually have a chronic illness. The pressure on our health system, we all know that, but it's actually the quality of life, of my life, that will be impacted in the next generation. I think that's where the outrage lies. I won't be able to do the things that I am able to do today because I am living a very unhealthy life.
Well said.
Wouldn't mind.
Well said, Yasmina. You're absolutely right.
Good point.
Absolutely.
I mean, we want to live younger, longer. Can we deal with that? Can our health workers, our health department, our hospitals, can they care for us so that we can live younger, longer? Dr.
Well,
Swan?
there's one of the dreams in epidemiology was something called the compression of morbidity hypothesis, which was this notion that we could compress morbidity, sickness, into smaller and smaller intervals so that you would live a relatively disease-free life right up until the time you passed, and that's sort of was the goal, and a belief that we could get there. I think what we've shown is the evidence has shown is that extended period prior to death has actually increased. So people living longer, managing. Now, that's not always a bad news story. I mean, there's a lot of things that can be effectively managed now that could not be effectively managed 10, even 20 years ago. But it's still the goal that we hope to do. I think some of the things that we're talking about around diet and lifestyle and physical activity are believed to be part of that solution of increasing quality of life, even if you can't significantly alter life expectancy or significantly alter, let's say, obesity rates. There are other benefits to that, and one of the benefits is certainly an enriched quality of life.
I think one of the, there is AHIW did a very detailed study on burden of disease, and we measure burden of disease using this metric called a daily or disability adjusted life year. Now, it's fantastic, it's accurate, but it's so hard to communicate to ordinary people. That's why I go for life expectancy rather than a daily, because people don't understand what it is. And so one of the things that I would really push for in this area, when you're trying to build metrics, ask, will your grandma or your mom or someone understand the thing that I'm explaining on radio? And they don't understand daily. So to me, all that work on the burden of disease studies that have been done, they're really not going to move the needle because no one can understand what a disability adjusted life year is. Am I being too harsh? Are there people in the audience?
You're absolutely right. You're absolutely right.
For policymakers and investment rather than.
Yeah, but what, as a policymaker, what am I deciding on? Yeah. You know what I mean? Like, oh, that's got Highdale. Oh, okay, so what am I doing that I wouldn't have done otherwise?
Rhema, I have tried that too with my mum and dad, and they sit there and say, "That's nice, dear." They have no idea what I'm talking about. But a 45-year gap, which you mentioned before. They cannot believe that that is the case in this state, and they are outraged by that.
But coming back to this question about quality of life, so I quoted that statistic, Swedish data, not Australian data, but the 80-year-old and your chances of dying in the next 12 months versus. There's lots of reasons for that. One is that you probably are a bit biologically younger because you haven't been smoking. You probably aren't obese, therefore you haven't got the inflammation going. But also and you've got to really tailor your expectations of the healthcare system. The healthcare system's contribution to life expectancy is very, very small. It contributes to individual lifespan. But when you get to 80, you might have had a new hip, you might have got a couple of stents, you might be on statins, which is this accumulating disability John's talking about, but the disability is livable with.
Yeah.
And doesn't actually destroy your quality of life. It's different from having had a stroke or you've got serious cognitive impairment. That's different. But most people can live with, Alan Lopez talks about this, the inventor of the DALI, is that we do accumulate disability, but it's not huge. Essentially, we get really sick 5 years before we die, and that hasn't changed very much. It's just the 5 years before you die is shifted to the right.
Yes, Jay.
So if I can comment on this, if I was actually brought out here to talk about aging, which is really my primary area of expertise, by the way. It relates.
Now we find out.
Yeah.
Jay, tell us about aging.
No, actually, it relates to this question, and it requires me to temper expectations. And so let me say it this way: the modern rise of heart disease, cancer, stroke, and especially Alzheimer's and neurological conditions expressed later in life are a consequence of success, not failure. These are the natural biological consequences of pushing out the envelope of survival in these bodies well into the post-reproductive period. It is not a failure, it is a success. It's one of the reasons why many of us in the world of aging are trying to attack the biological process of aging rather than just going after the diseases that are associated with it. And that would have been my primary message, but it relates to this because we have to be careful what we wish for. Living longer is not the goal. It's not the goal. It shouldn't be the goal of medicine. It's certainly not the goal of aging science. It's to make us healthier longer. It's exactly the title of your book. It's the extension of the period of healthy life, and there's metrics that, these DALIs certainly can be used to measure it, but we just have to be careful on how we think about this because we are using these machines longer than they were intended to be used, and we shouldn't be surprised when things go wrong.
But then the consequence of that is that we spend most of the money, healthcare dollars, on a person in those last few years of life. And we have to ask where, I always say I do medical students, I say, you're there when they're 85, and they're probably asking you, where were you when I was 9 and was facing these issues? Because you're not the health system, you should have been the housing system or some other system, if you see what I mean. So we tend to... So the question, health economists talk a fair innings, like do we as a society have to have a conversation about what we think a fair innings is, which is our responsibility to help to a certain extent, and at some point we are willing to address the issue of how much money we spend at the end of life. So I mean, that's a very controversial.
The problem is that we don't always know when the end of life is about to happen. Yeah. I mean, if you knew that there was 1 year left, there might be something that you could do. But the problem is that when folks get out past 80, 85, you don't know when that year is.
But, there are things you can measure, like chemotherapy within 6 months of death. There are metrics that you could use. And we've looked at, like, how much of our money do we spend on intubation when you're in ICU,
but
dying
then
in
what?
ICU.
So let's say you've identified somebody who's close to the end of life.
It's getting good
Do
now,
you
folks.
then
This is-
do you then withhold medical technology for these folks that are at the end of life? It's an issue that we've been dealing with in aging for a long time, and it's the value of life. And the argument that we've been making is the value of life is just as valuable for people that make it out to extreme old age as it is for children.
Yes. But we're in a conundrum. No one wants to pay taxes. Everyone wants to live forever, and we don't have enough to break intergenerational transmission of disadvantage.
I don't think it's as difficult a dilemma as you're saying, because I think what happens is a lot of health expenditure is throughout the life course. So your cholesterol's up, you'll go on a statin. Your blood pressure's up, you're going on blood pressure medication. Yes, you could have prevented that, I understand that. You might have played sport as a kid, need your knee or hip done. And those are all with no understanding of where the end of life is. But it is clear that particularly palliative care physicians are good at telling you when you're in the last 2 years of your life. And now you're talking about futile care. And we spend a lot on futile care. And that's where we need to have a discussion with patients and their families. Why are there screws in a coffin? To stop the oncologist giving a 4th round of chemotherapy.
This conversation and your question though reminded me of something, and it's an important element of what we're talking about here, which is the difference between trying to find an objective standard or measure and perception, which is particularly important around health. And I suspect the panel knows this, and many people in the audience knows this, but what most people think of when they think of the Framingham studies is that was the studies that told us about the dangers of cholesterol. But there were 2 other findings in that study that didn't receive the same degree of public attention that I think that should have. One was that if you ask people to rate their health on a simple 5-point scale from excellent to poor, the ones who rate good and above live longer than the ones who rate very poor and poor. And you can't explain it by the biological markers.
Right.
The other one, and you've alluded to this again, many of you have, is those that had reported higher levels of social support and feeling connected and a sense of belonging lived longer, and you couldn't explain those findings by the biological markers. And so we've come full circle again in thinking about the complexity of what it is that we're talking about, but also that there are a lot of common elements, a lot of common themes that keep cycling through our discussion, and these should be our targets for health promotion and health prevention, because we have the weight of evidence there that really does matter.
I'm just going to look straight at you when I say for us. I mean, thinking about us, we were brand new, and thinking about prevention in Queensland, there's just a limited amount of money here. So we've got to think about the aged, and we've got to think about middle age, and we've got to think about kids. And kids are the biggest bang for buck at the moment for us. Gen Q is the most important thing that we can do. And I'm looking at you because you and I have worked on this so many times. As well, it's kids. For us, it's kids getting it right. Whether it's their mental health, physical health, emotional health. This is the way that we can make change for us. So you are very, very right. I'm not ever going to get in between the two of you as well to talk about this, about life expectancy and about the ageing, because do you know what? I actually don't care. For me, it's about kids and getting it right there for me.
Round of applause, I think, for our panel this afternoon. We've run out of time. Thank you so much, John, Norman, Jay, Rhema and Robyn. Yes, a lot of things to continue to discuss, I think, there, probably at lunchtime when we break. But thank you very much, and just another round of applause as they leave the stage. Please stay there.